maintaining informal healthcare at home, and of course, the availability of a system where elderly people can have a safe space to have activities which prevent dementia, which would include engaging in cognitively stimulating tasks, either as learning a new language, puzzles, or Sudoku or chess, or memory games, and also physical activity, which is known to prevent dementia. So with this brief message, I will hand over back to the organizers and would be able to participate in the interactive discussions. Thank you.
Thank you, Dr. Manjari. Now let me look at some chats. I think one of those questions that has come up is, what is the difference in the role of a neurologist and psychiatrist, and of course the other supporting staff in caregiving for the elderly with dementia?
See, the management of cognitive disorders or dementia has to be a team approach. The neurologist is primarily responsible for the manner in which the diagnosis is made, because the diagnosis involves, certain history taking, skills of history taking, the skills of cognitive evaluation, which is based on structured scales. It also involves starting medication, which may have physical as well as other cardiovascular adverse effects. It also involves blood testing and sometimes lumbar puncture testing, and ordering advanced expensive investigations like MRI and PET. So really a very trained person has to do this. Now the psychiatrist comes into play because 60 to 80% of people with dementia at some point of their dementing illness will have significant neurobehavioral syndromes, whether it be depression, whether it be anxiety, whether it be aggression, whether it be wandering behavior, whether it be lack of sleep and keeping everybody awake at night. So the psychiatrist also has to give a rational prescription, because there are certain drugs which the psychiatrists use which can worsen cognition. So the psychiatrist also has to be skilled and trained enough that he does not use drugs which actually worsen cognition, and uses the drugs for the behavior, or uses strategies to tackle the behavior which are not having side effects. The other people who are involved in care of such a person is the informal or the trained caregiver, or the caregiver who is a family member. So these are all the people who are available in our country. But in some major cities like Delhi, Bombay, Bangalore, Hyderabad, and many other places I may not know or have not mentioned, there are facilities for daycare and chronic care, where patients can be taken in the morning and brought back in the evening, just like parents leave children in a play school, and be looked after with stimulating activities. So dementia management is a multidisciplinary approach. Physiotherapist, nurse, psychiatrist, the caregiver, psychosocial worker, neurologist, and the physician all have to be collaborators in this and not competitors for care. I think I've answered the question.
You did. Thank you. Thank you. Are there any other questions that any of you would like to ask? I think they're not ready for it immediately. Kindly suggest some of the evidence-based practices for person-centered care for individuals with dementia.
See, all medical care has to be person-centered. Public or mass programs or policies are just policies, but they become applicable only when it is person-centered. So person-centered would mean that you first define what are the problem areas. Is the cognition a problem area? Is the behavior a problem area? Or is the activities of daily living a problem area? These are the ABCs of dementia. So A is the activities of daily living, B is the behavior, and C is the cognition. So you first identify which is the major problem area. Then you develop strategies to tackle that particular problem area. For example, if activities of daily living is a problem behavior, So what is it? Bathing is a problem. So the person with dementia is taken to bathe. And when he goes to bathe, he's sitting on the stool and is being bathed by the family member. But the fellow has lost his memory. So when the daughter or daughter-in-law lifts the mug to bathe the person, he actually doesn't know what the mug is and what the bucket is because he's lost significance of both these items. And he actually thinks that the person who's looking after him is attacking him and gets violent and aggressive, refuses to have a bath and comes out. So the strategy we advise for such people is that yes, take them for the bath, but do not put the water from the front because the front, when you put the water from the front, it appears as if to say you're going to attack the fellow or the patient. So have more discreet strategies to bathe him, either sponge him from the back, or pour the water from the back, or tell stories, or make them listen to soothing music. So these are the kind of strategies which evolve around the problem area. So that is person-centered approach. Now, I can't give this approach to all patients with dementia. I will give it only to the people who have a problem in bathing. Similarly, another person-centered approach is that a person with dementia always wants to go out of the house. So they will say, I want to go to my daughter's house. So one of the approaches is that the caregiver says, you are in the daughter's house and puts the photo of the daughter right in front of the patient. So he actually thinks that he is in the daughter's house or makes a video of the daughter and that plays on. The other is to put a kind of a photograph of the door opening and closing or have a mock door opening and closing. So this is again person-centered approach. Thank you.
Thank you. I think last question, perhaps, Dr. Manjari, before we have the second speaker. One of them has asked you for a question. Please mention a facility for elderly diagnosis of AD in Hyderabad.
I think Dr. Suvarna's facility was there. She moved to Bangalore, but her team is very much there. And Nizam's Institute is there. So there are many private facilities, including your group. So I think they should approach them. Yeah.
Yeah. Thanks a lot. Would you continue to stay for some time, or you are going to leave?
Yeah, I will be there. I will be there.
I think you are probably one of the students. Your junior, Dr. Muralidhar Reddy, wanted to listen to you also. I hope he joins in because he had to take some permission and come. As Dr. Muralidhar has come. Sabak? He has not come. Okay. So what we will do is we'll go on with the next speaker, Rajarajeswari. Rajeshwari, are you ready, ma'am?
Yes, sir, I am ready.
Okay, thank you. I would like to introduce after talk. Thanks a lot, Dr. Manjari. We are very brief, very focused. I think there was no confusion about learning from you so very specifically. Thanks a lot once again. And next speaker, Dr. Muralidhar Reddy, is probably joining us a little later. He said he will come by 3:45, so I'm sure he should be there anytime. In the meanwhile, I'd like to introduce to you a very young lady called Dr. Rajarajeswari. She has done her MSc not very long ago, 2 years ago, 2018, 2020. She has worked in 2 major hospitals in Chennai before moving on to TSS Centre for Elderly Care in 2021, which is part of the SCARF, where Dr. Kshetra is heading the Alzheimer's care unit. And so she's going to talk to us about, nursing care. Primarily, our focus is going to be on nursing care for patients with dementia, since she has hands-on experience, and I'm very sure all of us would like to learn from her. Focus on that. Thank you very much. Rajarajeswari, take over.
Yeah, yes,
sir. Thank you.
Yeah, good evening. I'm giving the opportunity to speak for the Alzheimer dementia program and opportunities. Thanks. So I want to share about what are the nursing care for the patient with the dementia, what are the care we giving from our patient from here. So I just give the PowerPoint presentations. Yeah, please.
So Muralidhar Reddy, we just started. I just told Dr. Dr. Manjari that you would like to listen to. Rather, she would like you to listen to him. But anyhow, I've just started at 10 minutes. She will be over. Dr. Rajeshwari. Thank you.
Good morning, sir.
Is it okay if Dr. Rajeshwari completes it and you start, or have you got a commitment to go?
Yeah, that's okay, sir. No issue.
Okay, thank you. Thanks.
Yeah. So everyone is know about the what is meant by dementia. The dementia is a progressive impairment. Is mainly part of the language difficulty, the patient having the memory problem and poor judgment and difficult to completing the daycare routine also. For our for dressing, eating and hygienic and etc. As to what are the clinical manifestation for the patient having the dementia means mainly for the memory impairment. So difficult to thinking and the language ability, personality changes will be occur to impair ability to perform the motor activities and the disorientation, time, place, person. So it will be confused. Risk of wandering also there for the patients, mainly for the delusions. The what are the nursing care will be given for the patient with dementia means mainly to concentrate for the monitor the food intake.
Meeting Albin, meeting Albin.
Shall I continue? Yes. Monitor the food intake and
the security Mahendra.
Observe for the food habit and to promote the healthy skin for the patients and to healthy air and scalp and the bathing, how to give the bath to the patients and eating pattern and the toileting, how to prevent the bed sore, how to prevent the wandering and bonds, to give the dental care, communication and sleep pattern. Now you see by the one by one. To maintenance of the food level of nutrition means when you, for example, when your patient is to admission from the hospital, when that time means to check the weight of the patients, and otherwise you can't check the weight to do the midterm circumcision. So provide the regular mealtime schedule. For example, the patient வீட்டர் கொடுக்கும் hospital time mealtime and variation. In hospital we maintaining for the 8 o'clock food, 11 o'clock snacks, 1 o'clock to 4 o'clock snacks after 8 o'clock food. So maintain the regular mealtime is very important for the patients to encourage for the adequate meat intake. Yes, the dementia patient did not ask the water to be take a meal mostly the bucket for the meal. So now I'm going to time schedule, put the time schedule and to give the water for 2 hours once or 1 hour once for the in case the patient who refuse to drink water means we give for the juice or soup and more that type of milk you can give, that type of liquid diet you can give. Next, for the personal hygiene. Personal hygiene, the skin is very important for the old age patients to maintain the skin hygiene, to lubricate the any skin are dry. In case you do not give the proper skin care means the patient who having the eczema, itching, that is also who having the complaint of most of the old age patient complaint. So mainly to prevent the skin care in the bed sore. Bed sore is very important. In case the patient who having the eczema means to give the cloth to wash it separately because to not spread for the other patients. So assist the back and protect food and cat prevent the bed sore and provide the clean and the dry under the cloth is very important. In case the patient to not willing to apply some of the favorite lotions, the lotions apply they're very happy to apply. Next, to promote the healthy air and staff. Yes. Give the bath to the patients when weekly twice hair bath confirm to apply the oils to and give the comb on the proper neat and comb that will be very happy. To avoid for prevent for the pedicures. Yes, in case the patient were having the pedicures in the head, having the some disturbances, the restless and agitation, so on the issues. So just prevent that. To encourage the nail carriers to maintain the clean and short nail for the both estimates in case the nail is improper means that some of the infection is going for the inside of the stomach, so loose motions and the etc. So to avoid food poisoning, so just to give the proper nail care to the patient. Next, for the eating. So eating means to give number normal patients to food in case so normal hospital or patient food in case a dementia patient food is different. When a patient food அப்படின்னா அவங்க ப்ராப்பரா வந்து பிளேட்ல வைக்கிற எடுத்து சாப்பிட்டோம்னா இட்ஸ் நாட் அவங்க ப்ராப்பர் ஃபுட் எடுத்து சாப்பிட மாட்டாங்க. அது வந்து ஃபுட்டு வந்து இட்லி இருக்குன்னா அதை சட்னில மிஸ் பண்ணி தான் சாப்பிடணுன்றது அவங்களுக்கு தெரியாது. நெக்ஸ்ட் வந்து நீங்க ரைஸ் வச்சாலும் அது காயோ மீன்ஸ் நெக்ஸ்ட் சைட் டிஷ் என்ன இருக்கோ அதை மிஸ் பண்ணி சாப்பிடணுன்றது தெரியாது. ஜஸ்ட் அப்சர்வ் ஃபார் த நர்சிங் அசிஸ்டன்ட் ஆர் சூப்பர்வைசிங் த பேஷண்ட் when eating food. In case the patient வந்து ஃபுல் இட்லி எடுத்து சாப்பிடுறாங்க அப்படின்னா we just cut down the food and smaller pieces and mix the food and food.
ராஜேஸ்வரி டூ திங்ஸ் மா. ஒன்னு வந்து கொஞ்சம் ஸ்லோ பண்ணுங்க, நீங்க ரொம்ப வேகமா பேசுறீங்க.
ஓ சாரி சார்.
ரெண்டாவது கொஞ்சம் மைக்கு பக்கத்துல வந்து பாருங்க. people are telling they are not able to hear you.
Okay, yes.
மூணாவது முடிஞ்ச வரைக்கும் இங்கிலீஷ் பேசுங்க, ஃபுல்லா தமிழ் பேசுங்க. ஏன்னா இந்தியால இருந்து வெளியில நிறைய பேர் இருக்காங்க. அவங்களுக்குலாம் யாருக்கும் தமிழ் தெரியாது.
Yeah, sorry,
தெலுங்கானா,
sir. I just
தெலுங்கு,
interrupted.
ஆந்திர பிரதேஷ், கர்நாடகா அங்கெல்லாம் இருக்காங்க. I'm so sorry to interfere.
Yeah, it's okay. No problem, sir. I just explained.
So slow down a bit. Thank you. மெதுவா
Yeah.
பேசுங்க, ரொம்ப வேகமா பேசுறீங்க. Thank you.
Okay. To ensure the patient had the food and to provide with most balanced diet. In case the patient could not eat the food properly, means in case they eat the full, it means you just cut down the food in the smaller pieces and mix the food and give good thing and to encourage the soft and liquid diet. In case some patients who are having the risk of aspirations, means you just give for the soft diet and to liquid diet to ensure the client would get more of that. So most of the older patients who can't eat the food properly, so just give for the most in the semi-solid is eat it properly, so eating easily. And to diet supplemented like calcium and vitamins, because what reasons means the patient who have old age means the deficiencies of the vitamins and the calcium also. So
Excuse me. Could you please check your mic? Your voice is like cracking, not able to.
yeah, now is audible, sir. Hello.
Yeah, it's fine.
Yeah, now sir.
Yeah, it's
Check once or twice before she talks. Check once again. Ask her to talk once or twice.
Yeah, my voice is audible, sir.
You are much better before. நிறைய பேர், lot of people are writing that they are not able to hear you.
Oh, sorry.
Break. Don't worry, man. Thank you.
Yeah. Now is audible, sir.
Yeah, please.
Yeah. So next we going for the bathing. Bathing means you give the bath to the patient, so never towel the patients. You give for the hot water only to encourage the patient to hygienic and avoid the deficiencies on the caregivers. For dementia patient, you give the bath to the dementia patients means some of the patients to refusing to bath. So just encourage us to give the bath. You give the hot water means just the caregiver is not to leave the patient as alone. In case they take the water and applying in body means it going for the pools. So and to provide the bath stool in case the patient can't fit in western means we give the stump stools and sit and craft rails inside the bathroom for the support to walk. Keep the bathroom inside dry, clean and etc. because to prevent the falls. In case the floor will be water, means the patient will get the falls. So try to prevent the falls. And to give before you give the bath means to check the temperature of the water is very important. Some of the patients are to like crowded soap and the shampoo and the hair oils. You just give for that means the patient very interested to take the bath. To observe for the any injury and the source when you give the bath. Yes. In case the patient is bedridden means you do not observe anything means when you give the bath to the patients to observe that any injuries or dead stories there in attacks are. Yeah, already we did. Yes. So next monitor the water temperature already told it. So encourage the safety measure and mostly you don't use the any mat, rubber mat in the inside of the bathroom. In case you keep it with the patient when you walk means they get the falls. So we try to avoid the bathroom mat, rubber matters and to avoid to wear the patient chappals. So toilet training, yes. Is very important. Most of the patients who having the constipations means we did not take the proper intake of the food. So we try to prevent the constipation and the dehydration. To assist the patient to toilet schedule interval. Yes, in case the patient don't know how to pass the motions or urine at all. So we put some schedule. In case the patient 8 o'clock to pass the urine means after 10 o'clock you just go for the toilet. Mostly the toilet training patient bed you give for the so in case the patient is in the diabetic means bed you just use opposite toilet you just give to him. So you just give that automatic you just give means the patient to easily to pass the urine restroom to the know how to give for the way to restroom. Use the signage and the simple reading to the toilet and use the night light and craft lights in the toilet and provide the easily removable garments and keep the toilet clean and dry. It's already told. Next is communication. Yes, is very important in the dementia patient. To use the simple sentence with the simple words. You don't talk to the patients. Means you continuously talk. Ask there, how are you? Where your breakfast? You just ask the continuously. The patient did not understand what you are going to say. To use the simple sentence with the simple words and speak clearly and slowly. Take time. Hi, sir. How are you? hi sir, how are you? You had your report. You start like that when the patient to understand it little bit also. And to give the patient time to understand before to continue the next sentence. Yes, continuously you talk to him, the patient is not to understand. To observe the client verbal and the non-verbal response. Yes. Some of the patient to open when you ask the question means that they open the mouth and say the answer. But some of the patient say the answer. You see for them eyes rubbing, eyeball movements and their fingers touching, fingers movement. It is for the non-verbal response to the patients. And use the some of the gestures such as to pointing to the object or demonstrating to the action to be done. In case the patient to having the hearing impairment means you just write the one blackboard and choose to show to the patient either English or Tamil. To avoid the distraction when you talking to the client, yes, you just talk to the patient when you not any to avoid the distraction because the patient thinking you do not listen the words to the or her. So you just give the proper communication to the patient. Next is mouth care is very important to the old age patients. Not maintain the proper mouth care to promote the regular mouth care to encourage the care of in case the patient mouth will be getting any oral thrush or ulcer or into wearing the artificial denture means it is in uncomfortable means the patient intake will be disturbance. The feel some restlessness, will not take the proper food and the risk of aspiration is there. In case the attention will be very loose means the patient with swallowing up will be there. So just to prevent, so deep for the mouth care is very important to encourage the care of gum and teeth after the meals and to encourage the client to meet and the clean. To monitor the dental hygiene and check for the any halitis is there. To assist the brushing daily, as the patient will not do the brush daily, so but we only company the assistant nurses or the nursing supervisors only to supervision the patient to brush daily or not. Use the very soft brush. Yes, in case the brush will be very hard, means the patient will not brush. So it will be very soft than some favorite color. So if they turn on, you just choose and give them. You know. And check the mouth for any sores or ulcer is very important. In case the patient who having the any mouth ulcer means did not take food properly. So refusing to take food. And use the correct fitting of the tension as this is also important. In case the patient who having the any tension issues means immediately you consult on the dental doctor. In the having the gum tone is there. In case we have patient who having the loose denture means you just apply the gum tone in the denture, so just fix it. So most of them using now, but you try to avoid the fitting. Use the correct fitting stitcher tension because the risk of aspiration is there. Use the humidity to prevent the drying of lips. Next is wandering. Yes, is mostly happen in the dementia cases. So, but if we are doing into mostly to locking the patients in inside of the rooms, so just avoid. But avoid panna mudiyala, but we doing that. To identify the bracelet for the risk of false bracelet is there. We just mention the name, address, and the telephone number in the bracelet. In case the patient is going out or anyone is seeing the person to call the number and inform us. So we just use the bracelet and relocate the door locks to position where the person will not look for the yes. But mostly we not using from here, I think so. But we do that. Instead, the bells are buzzed in the sound when the external doors are open, but it's very rare only because of some of not only the wandering patient is going out, the bells are buzzed, it did not sound. In case normal patients, the nurses or doctors is going out, the alarm will still sound. So just avoid that. Make the door less visible by the painting in the same color and covering it within the curtain. Yes. In case when the opposite, in case the patient open front of the door is having the white color means inside of the door also you just keep the any white color or any same color in the inside of the door. The patient thinking it is not a main door, it's for the close, not main door or the thinking of it. So mostly we are using for the GP tracker for the patient's risk of concentration. So also advice for the family members also to use for the GP tracker. Next, bed sore. So bed sore can happen when the person is bedridden, otherwise immobilized, unconscious, is unable to sense the pain. So mostly the old age patient who are having the bed sore means we try to prevent the pain. for encourage. So how to prevent in case the patient were having bed sore means how to prevent. So prevent the bed sore means to turning or repositioning every second hour and sitting the upright straight in the wheelchair and changing position every 15 minutes. We are not the bed sore care, but mainly we using for when patient having the bed sore means try to avoid the diaper. In case you're using the diaper means the patient diaper is any motions or urine means it will be touched for the urine to get the infection more. They not to heal properly. So maybe the patient in the night is sleeping in the bed, we try to keep the wound open only. So give for the more protein rich diet to the patients to prevent heal the bed sore easily and providing a good skincare too. When you're doing the dressing, please do proper hygiene measure. It's very important. In case you touching the motion or change the diaper and immediately doing the dressing means it get infection, it not heal properly. Mostly used for the hair better. Is it be very useful for to prevent the bed sore to the patients. And to whenever you give the food also, in case they are mostly the old age patient to avoid to take the food means you give with them more of the juice, water, so is already I told you. So it just continue. So aspiration, yes, is mostly to happen for the old ages. So when you give the food to patients to be head elevate and give the and water, etc. Mostly good for food and semi-solid food. In case some of the patients who take water also, we get a severe cough. So we using the xanthan gum and the ticket powder. The xanthan gum is available in our country, but ticket powder is available in US only in case the patient wants to take. Aspiration patient drink water. Taking severe cough means do not give the any water. You just put the ticket powder or xanthan gum in 2 spoons and to mix the water and that it will be get very thick. When you mix water means powder will get thick. After this, it give the patient. Okay. So monitor the medication. Yes, is no everyone is means one is dementia patient will not take proper medicines to administer at appropriate time and should not to leave the medicine by the patient. Yes, patient will give the medicines mean do not. Some of the patient will swallow the medicine. Some of the patient will spit the medicines. Some of the patient to keep the inside of the tongue or else floor of the tongue. So when you leave the patient in the chest is in the medicine. So mostly supervision is very important when you give the medicine to the patient. Next one is in case the patient to refusing to take medicines, you just give for any fabric juice or a protein powder, you just mix and give to the patients with that drink. So after this, you just explain to the family members also to how to give the medicines after discharge. Next is a false, yes, it's mostly to happen in patients. So in case the how to prevent the false means to arrange the adequate lighting in case the patient night is sleeping in the room means to give put the more light in the bathroom and the patient rooms also. And to provide the visual cues. Yes, in case the patient having the visual impairment also to having the risk of falls there. Medication, yes, you give the any sedative medication, given the medication, but the patient not sleep that night, the falls is at them. Clear walking not inside of the room. Yes, in case patient room is there, but for mat, bed opposite any cupboard or any sedative devices is there. If the patient will not see seen at night and the injuries will be occur. So try to prevent the don't put any unnecessary things in the inside of the rooms of the patients. Orthostatic hypertension. Yes, some of the patient is going for the restrooms or bed means suddenly suddenly get giddiness and get falls in the falls. Because the reason is the patient are taking any medicines or any BP issues is that means we did not see that we having the problem, patients having problem, but we not feel means we having the risk of falls is there. And keep the important things in the patient bed. For example, water, book, and classes, reading classes. And consider the unmet needs. Yes, already we told that. Don't give the rubber mats or chapels in the inside of the bathrooms. It's also to have patient risk of falls. And keep the health hand. And supply for the food, safe food. Yes, in case patients using the high heels or rubber false chapels means it will be get injured. So using the bathroom, this type of graph pads, when going patient restroom is very useful to keep supporting. Incontinence, yeah, incontinence also one of the reason for patient falls. In case the patient the urgency of the urine means like they're going for very fastly going for bathroom, the fast. For unnecessary equipments, it keep in ward or hospitals and room means that time also. So sleep disturbance, yes. Mostly we know about the dementia patient to having the sleep disturbances. My voice is audible, sir? Hello? Hello?
Go ahead, ma. Go ahead. Keep doing.
Yes, sir.
Keep doing.
Yes. Yeah, dementia experience to excessive in the daytime sleep in case the patient to having most of the dementia patient day or night will be confusion is there. So in case you did not give any activities at the daytime, the patient is sleeping at daytime means nighttime the sleep disturbance will happen. So try to prevent the daytime sleep to the patients. So give the any activities for carom, coloring, watching the TV, the music, reading the book. You just encourage the patients and to provide the daytime sleep. So monitor the food temperature is very important. When you provide the food to the supply the food to the patients means you adjust the temperature of the food. You do not give them a very hard food to the patients. So already to encourage the performance activities to perform art, chase, and walking in terrace or garden, and take the patient and to go for any shoppings with a nursing assistant or supervising support, and go for any park. So did not keep the patients inside of the room. Don't keep them inside. So next one is provide rehabilitation team to problem support and extend the existing skills to provide the physiotherapy as in case the patient is not mobilized properly means we give the physiotherapy. And other is the difficulty in most of the ortho patient is there for in our environments. In case the patient having any arthritis, as rheumatoid arthritis is there for physiotherapy and providing the is in case the patient having the hearing impairments to check the hearing consultation and to provide the hearing aid to the patient and to give the speech therapy under the language deficit therapy patients to give the speech therapy. Impaired vision means to provide the big letter in the books or schedules. Reading classes is keep necessary as in case the patient to reading the newspaper or reading the book or showing any communication means the patient reading class is very important. Just bladder and bowel training is in try to prevent the incontinence of the patients. So nursing diagnosis that you can use for two nursing care plan to dementia is risk for trauma is there for the patient regarding related to the disorientation and confusion. Risk for self-directed and other directed providers related to additional thinking. Chronic confusion as a day and time and place person is everything. This is the chronic confusion to the patient. Self deficit is related to cognitive impairment and risk for faults is related to cognitive impairment. So it is the patient having the confusions or disorientations to any physical issues in the past mostly to affect the patients. Yeah. Thank you, sir.
Thank you, Rajeshwari,
Yes.
for a very comprehensive picture that you spoke about the nursing care.
Yeah, thank you. Thank you.
Thanks a lot. You covered by a lot of things. There are two questions, but I will come to you after Dr. Muralidhar Reddy finishes because he has to go for his clinic. So therefore, we will.
Yeah, okay, sir. I'm waiting.
If your time permits, two questions that you need to bear in mind.
Yes.
How to avoid choking while patient is fed? That's the first question.
Yes, I would try.
No, don't answer now. I'm going to come back to you. The second question is, what is the role of nursing assessment in the long-term care of the dementia patient? These are two questions. We'll come back. Now, with this, I thank you very much for making a comprehensive. There has been a lot of disturbance in your audio. I don't think you could avoid it because I think internet problems were there, but otherwise you covered it very well. Thank you. Now we have Dr. Muralidhar Reddy. Dr. Muralidhar Reddy is a consultant neurologist at well-known care hospital, super specialty hospital, and transplant center in Manjari. And he has a clinic OPD center in Banjara Hills with indoor facilities, large number of beds. He has 11 years of experience in the field of neurology. He has successfully operated many people around the world. He is a DM Neurology, ASN certified neurosonology. He completed MBBS from SB Medical College, Mehboob Nagar, and later did his DNB medicine from Nizam, well-known Nizam's Institute. And he is one of those persons who is consulted on dementia care, particularly in Kshetra. And I'm sure he is involved in other programs as well. And so he is not new to addressing such groups, and he carries with him a lot of experience to share his experience. With that, I invite Dr. Muralidhar Reddy to take over. Thank you, Dr. Muralidhar Reddy, for being so gracious to accept our invitation despite being extremely busy in the evening hours. We understand your time management can be challenged by us. Extremely sorry, but at the same time, we express our deep sense of gratitude. Thank you once again.
Thank you, sir, for the kind words. At the outset, first of all, I would like to thank Dr. Pavitra and Dr. Gangadharan, sir, for inviting me for this lecture. Am I audible and am I clear, sir?
Clear, absolutely clear, absolutely clear. Thank you.
Okay. Are you able to see my screen too?
Very much, very much.
Okay. I would actually touch upon the very few medical aspects. So actually, the topic I chose, I felt actually many of you may not have heard. So I will keep it very simple. This is actually a 13-14 slide presentation only. So many of you are patients and also nurses and also people who take care of dementic patients, especially Alzheimer's. And I would just give you some backup about what happens so that I'll build up a story in that way. So how the disease progression in Alzheimer's, most of us know that it is not a curable disease. To some extent, we can help the patient with some non-pharmacological and little bit of pharmacological measures. So many people and a lot of family members will have doubts what is the prognosis, what to plan, what to do further for my mother and what to do for the family. So for that, actually, we should have little bit of medical knowledge about the Alzheimer's disease. Let me go ahead. I will just, because to actually come to solid conclusions of what to do and what to plan at what stage, what to do, we should know little bit about how it actually progresses and what is the basis of progression. My voice is clear now, sir?
It is very
Absolutely
clear.
clear. Absolutely clear.
Yeah. So the next slide would be, the first slide would be, this is actually, I would say, actually a very, very important slide. So as if my arrow is actually showing on the x-axis, there is something called as a progression of the disease. Alzheimer's is a dementia. Dementia means the main component of it is actually forgetfulness. Actually, initially the patients will have a normal cognition. That means normal brain thinking and normal kind of brain functions. Slowly, it will actually progress to the mild cognitive impairment and leading on to frank dementia. But before this dementia happens, there will be a lot of these lines that will be happening in the brain. So each line is colored. First, actually, what happens is there will be something called as amyloid. These are many technical terms, but just remember that there are two proteins which are actually important in Alzheimer's disease. One is amyloid and one is tau, T-A-U, tau. So first of all, there will be amyloid deposition. Amyloid and tau are normally present in the brain, but they are recycled properly in a normal brain. What happens in Alzheimer's disease is these proteins are not recycled. They get stored in the form of protein complexes. The complexes are not actually broken down. When these complexes are not broken down, they tend to accumulate in certain areas in the brain, which lead to many structural problems. First, there will be amyloid plaques and also tau neurofibrillary tangles, what you call. When these actually cross one limit, then there will be some brain structural damages. These brain structural damages happen in certain areas, certain specific areas in the brain, and they follow a certain pattern. it goes from one area in the brain to the other area of the brain. Slowly, the patients will have memory impairments and there will be functional deficits. They will be severely limited to do their daily activities. This is the way how it progresses. So as the amyloid plaque burden and also tau fibrils, tau protein burden increases in the brain, so the neurostructural damages that happens in the brain also worsen. And as a result, the memory and also the functional deficits keep on accumulating. So this is the way it actually progresses. So going on to the next slide, what actually happens in the brain? So as you can see here, again, this is again on the x-axis, there is something called as a prodromal phase to flank dementia. As you can see, the red line, which is actually the amyloid, the blue line, that is actually the tau tangles. Slowly, these accumulations will cause neurodegeneration and a cognitive deficit. So actually, there is something called amyloid hypothesis and tau hypothesis. I will just rush through very briefly on this because going into too much details, there are a lot of books on these subjects actually. I wanted to keep it very simple. There is something in everybody's brain called as an amyloid precursor protein. This is called as APP. Usually, it is actually broken down to form amyloid beta fibrils. Actually, these assemble and there will be a lot of protein aggregates like this which form. These aggregates normally will not form in a normal brain. But these aggregates, if they are formed and they cross one limit, then they cause damage to the cells in the brain which are responsible for the memory. There is another hypothesis called as microtubule. These are actually tau proteins. This is actually stabilized. When they phosphorylate, they get destabilized. When these destabilization involves actually the dimer, oligomer, and they form actually called as tangles, which cannot be lysed, and they again cause cytotoxic. They damage the nerve cells which are responsible for the brain function. So if you see this actually a maze, you see that there is an A is amyloid, then going on to tau. If you actually come to the periphery of this maze, slowly there will be loss, synaptic loss. That is, synapse is nothing but a connection from one cell to the another cell in the brain. There will be loss and there will be a slowly neuronal death. There will be oxidative stress, and finally there will be damage to the brain. So this is how it happens. So how it spreads? Now I told you that there are two proteins which are important. These two proteins are usually recycled normally in the brain. If they are not recycled properly and there is their metabolism is their metabolic fragmentation is abnormal, means then they tend to accumulate. These accumulations will cause memory problems. Obviously, the more number of abnormal proteins in the brain, the more will be the memory problems and functional deficits. Then how they accumulate in the brain? In every brain, but see, there are a lot of dementias. In some dementias, we don't see memory as a first picture. We see actually there is one disease called as frontotemporal dementia. People have behavioral problems. They don't have memory problems in first go. There are some dementias where there are subcortical signs. They become very slow. They become very walking difficulty. There are some variants of Alzheimer's where there will be visuospatial problems. They cannot locate properly. They cannot name properly. Because this happens because there are various areas in the brain which will control various functions in the body. So, for example, these you must be all familiar after this 3-day presentation that Alzheimer starts with memory problems. Memory is actually controlled by the lobes called as temporal lobes, mesial temporal lobes. The protein accumulation which happens because of amyloid or tau first accumulates in the mesial temporal lobe. Then slowly, as you can see here, the second picture, it is accumulating in the mesial temporal lobe. Slowly, it will progress to the parietal lobe. Then slowly, it will actually progress to the whole brain. When these protein accumulation happens in the whole brain, then we call it as a final stage of dementia or advanced dementia. I will come to those technical terms later. So, but this is a MRI. Many patients will get MRI done. As you can see, these are the temporal lobes as I am actually showing here. If you can see in the MCI phase, as you can see, there is some atrophy. These black areas have become more prominent. This where I am actually pointing. Whereas in Alzheimer's disease, there is a lot of the cortical atrophy only. This we can actually do by the PET scanning. This is actually a normal brain that you can see in the last picture. All the red areas actually are amyloid picked up areas, and whole brain got abnormal. So this is the way it progresses. For this, actually, there is a staging system. In amyloid disease, in Alzheimer's, there is a staging system, though it is actually formulated by different organizations, different groups, working groups, and other things. The usual, very commonly followed one is NIA, national, this one, NIA group. Actually, this is an association. So what we call it as a preclinical AD. This preclinical AD is where the patient will not have any symptoms. Before presenting to us only, patient will have some amount of the problem going on in the brain. From preclinical stage, the disease slowly progresses to the MCI, that is minimal cognitive impairment. From here, it goes to the mild dementia, moderate dementia, and advanced or severe dementia, what you call. In this phase, actually, the protein accumulation is widespread, and it is present all over the brain. So this is actually the staging pro. Now the next question from many of the patient attendants and also the many people who, how long it will take from one stage to go to other stage. My father has actually a prodromal or a minimal cognitive impairment. How long will it take to go to mild dementia, moderate? Is a very common question. There brings the next slide. It will take a long time from the mild cognitive impairment phase to go into frank dementia or advanced stage. It will take up to 15 years. So a patient who actually starts and comes to mild cognitive impairment, they will have a lifespan of around 15 years to actually get their functional limitation very marked. So this is the way it actually progresses. If it is progressing very rapidly, there are some atypical cases where the progression could be very rapid. Sometimes if the progression is very rapid, then we have to actually think of dual pathology. There could be mixed dementia where there could be vascular component also. There could be some other treatable components like V12 deficiencies. We have to actually decide about getting more tests done when the progression is very rapid. I still seeing Kshetra few patients who were admitted with the actually the mild moderate stage of dementia. Over 5 years to 6 years, they have gone now to advanced dementia. I'm while narrating this slide, I'm getting recollections of those patients whom I've seen in Kshetra who actually worsened over 5 to 6 years to reach this stage of advanced dementia. So now this is about the pathology. So first we have dealt about what are the proteins, how it will affect the brain, then went on to the stages, and then I told how long it will take. Now obviously many of the patient attendants and also the patients and also people who deal with dementias will want to know what are the symptoms that present in the prodromal or mild stage, moderate stage, and severe stage. So prodromal, so there comes actually what I will do is actually we will segment the symptoms into three aspects: cognitive aspect, behavioral and psychiatric aspects, and functional aspects. So cognitive aspects are predominantly dealt by the neurologists and the neuropsychologists, whereas behavioral and psychiatric aspects to some extent are dealt by neurologists, but beyond one point we have to take the help of psychiatrists. And functional deficits, we need lot of help from the caregivers and also nurses. Caregivers obviously have role at every stage, but they become obviously completely dependent on you. So what I will go through is first I will these are actually the symptoms and cognitive aspect. Cognitive aspect, we mean there will be difficult, they won't be able to actually um, um, process the information as others do. As I'm actually reading it, this is the stage 1, stage 2, stage 3. Stage 1 is actually a prodromal phase or minimal cognitive impairment. Stage 2 is a mild, moderate, and severe stage. So uh, I will in subsequent slide tell you how to identify by what kind of scales which we use to do all these things. So in stage 1, actually the patients will have mild anomia and mild personality changes and mild forgetfulness. They usually tell, I'm not able to recollect things. Casually we talk, but when you actually ask the person the next day what happened, they may be not be able to recollect what happened, but they may be able to do all their daily activities normally. So they are actually to look completely normal, but there are some memory problems. They find difficulty in switching off the stove. They make mistakes while cooking. They forget which friend has talked to them, which dog, which they forget what conversation they had yesterday with the parents and with the, I mean to say, with the family members. So that is the stage, but they are actually functionally independent. They can dress themselves well, they can take care of themselves, they can comb themselves, their self-care is all good. That is actually called as a stage 1 dementia. When you come to stage 2 or mild dementia, they will be having difficulty in memory loss. The memory loss in the sense that they will not be able to actually recollect what they ate in the morning. They keep on asking. Usually, such patients, we see తెలుగులో, ఐ మీన్ ఇన్ తెలుగు we tell, బాగా చాదస్తంగా ఉంటున్నారు, వయసు ఎక్కువ అయిపోయింది కదా. They keep on asking same thing on and on. They keep asking about granddaughters, whether she has come, and again they will ask the same thing. After 10 minutes, did granddaughter come? Some person goes out, did she come? They keep on asking the same thing. They will start developing difficulty in naming, not able to recollect the person who comes home, who was very reasonably very close to their family. They cannot actually operate the remote. They used to operate before. They used to open the book and read. They will not be able to know how to actually operate the remote and their cell phones like this. They will have difficulty in speaking. Some color names they may forget. They will not be able to recollect the colors and all those things. They may develop some wandering aimlessly. So in stage that is a moderate stage, they slowly develop, lose the severe functional impairments and loss of lot of cognitive complaints. They they have difficulty in navigating into the kitchen in their home, inside and even outside also. And in advanced stage, actually they become completely dependent. There won't be any coordination. They will be that is a phase actually they need somebody to actually support. So these are the stages, these are the cognitive complaints which actually this all happen as the increasing amyloid burden and also tau burden in the brain. So, but it will take some days to actually go from stage 1 to 2 to 3 and 4. And these are various behavioral and psychiatric aspects. Some people can have hallucinations. They may actually see some objects, some insects crawling in the home, somebody actually peeping through them. I remember one patient of mine who constantly tells there is somebody who is seeing me from the opposite house when there is nobody. And they may have anxiety, they may have delusions, and they will be withdrawn. They don't actually take any kind of initiative. They just sit like that. And even we have to push them to actually take bath also. And they will become very depressed, and they may become disinhibited. They don't know what to talk. They actually pass urine and also motion in the clothes, and they may not have much guilt. They have in social disinhibition, and they will have very motor restlessness. May become very slow, agitated, all these things. These are all the behavioral and psychiatric complaints. To some extent, they are dealt by the neurologist, and these behavioral aspects are dependent upon minor changes in day-to-day activities. Actually, I remember in last previous years edition also, one nurse was actually telling about the people they have loss of flight, and also, I mean to say, that stress response in Alzheimer's disease is completely lost. So people have very rigid mentality, so they actually stick to what they're actually thinking. So we have to be very empathetic to them. They don't actually adjust like we young generations, and also we actually adjust easily, but they cannot adjust to new environments. Even if a new cook comes to the home, they cannot adjust very freely. I mean to say, they think that it is completely foreign. Even some objects are put in one place in the room. If some object is displaced, they feel that this is not completely their room. They have a very rigid kind of state of mind. So these are the various behavioral and psychiatric aspects. To some extent, sometimes we need to take psychiatrist help also. And sometimes they will have difficulty in functional, so they can have difficulty into doing their day-to-day activities. They will have difficulty in maintaining their hygiene, brushing teeth, taking bath, and wearing clothes. They may wear it upside down, they may wear it actually right to left. They will have confusion to wear the chappals, whether to right or left. They will have difficulty in managing the money. They get lost ways when they go outside temple. They cannot actually navigate backwards. They need they forget actually performing the puja. They actually forget how to eat also. They forget how to actually make their groom themselves, their hair. These are all the functional aspects which actually happen in a very advanced stage. So it is actually better to divide the symptoms into cognitive symptoms, behavioral symptoms, and functional aspects. And all these things will be occurring simultaneously in the brain, but these actually become more and more profound as the burden of the disease also in the brain worsens. So this is a very simple slide, diagnostics and drug. As you can see here, actually there are various tests that we can do in the initial phase. These are the cognitive scales which I told. These all are done actually in Kshetra, MOCA, MMSC. These are done by neuropsychologists. With that, actually we can assess which parts of the brain are abnormal. So we may need MRIs and FDG PET scans to actually make a diagnosis. Sometimes if it is very early, FDG PET is useful, amyloid PET CTs are useful, and in very advanced stages, and these are various drugs. So in the early stages, there could be ACH inhibitors. I am not going into all these things because these were dealt before. My these were dealt before. So these are in this way actually we work up the cases. So now I would like to concentrate on the advice, what we can do, what sort of advice, what can they can do in the mild stage, moderate. In the mild stage, actually safety of the person is very important. Now we elderly are very independent. Like West, actually even our elders actually they stay alone. But I mean their safety we have to actually check them. If you feel that they are unsafe to stay alone, it is better actually to constantly check on them, at least every day or alternate day. Check on them, what actually are doing, what problems they are actually facing. Safety, I mean to say, just now I gave an example, switching off the stove. If they can't switch off the stove, if they can't if they don't forget to actually light after the stove is switched on, then these could be very different problems which altogether have problems. So safety always is a very important thing which we have to assess in our people, and we have to identify stressors, and we have to try to avoid the stress. Even the mildest stress actually it can worsen the symptoms sometimes, and we have to try to work together. And in the early stages we have to try to retain their always any person likes to be independent. Elderly patients try to be independent. We have to retain their independence. Whenever they are actually interested in doing some activity, we have to help them do their activity and maintain their independence as long as it is possible. So working together is also very important, and we have to encourage a physical activity as far as possible. We have to actually give a balanced diet, and you have to fix a daily routine for them. Do this, do this, do this, so that actually they will be used to that sort of routine thing. And we may introduce some support groups, and we can give some drugs, and also we can suggest them family members. There are some trials, some centers doing some trials on Alzheimer's disease, and we can introduce such trials for them. And more important is, because it is not curable disease, we have to plan the future of the patient and also the family appropriately. These are the things which actually caregivers may have to be told properly. In moderate stage, actually I told, in while dealing with the moderate, they have very rigid mind, so they cannot actually tolerate actually people telling against them, or suggest I would suggest actually don't tell no. If they actually tell somebody is peeping through the window, actually yes, I'm also yes, correct, let it be, he will go after some time. So in that way we should actually maintain a calm demeanor, and actually we have to actually try to tell straight no nos. No, no, that is as simple. And we have to try to empathize with them, try to spend time with them, and we have to try to solve their problems with the conversations. We have to give them any suggestions which we can actually try to solve their problems, what we can do. Give an open-ended question, what can we do, what should we do. I remember one patient in Kshetra, only a doctor from US. I mean, Pavitra could maybe be able to know. I won't say name for this thing. That person is a doctor from US. He was very, very adamant and was not at all willing, comfortable to be seen by me in Kshetra. But later, when we talked after one visit, two visits, he was very fond of Harrison. I remember getting Harrison for him, my old Harrison for him, and I left 1 month with him only. He wanted to go through the Harrison. So we have to actually talk to them and the suggestions. We have to empathize with the patients too. And you have to give reminders also. Reminder slips all along in their room, what we have to do, these things in such way. But till the last event, we have to maintain, this is a very fine balance. We have to maintain, we have to find out which areas they need dependence, which areas they need independence. We have to leave some things independently to people, because people love independence. So we have to not make them completely dependent on that. And I remember many sons and many children coming to my OPD and also outside to strictly warning their parents, don't do this. We tell so many things, this, don't do this, don't do. A small stroke, they keep on telling, don't do this. You tell doctor, my father is actually willing to drive. You don't, you tell him not to drive. They want to put me through so that it actually goes to the patient. But patients love independence. Actually, we also treat the patients, not only dementias, other things, to actually make the patient become normal to the previous state. So what we call MRS as zero. MRS is actually a scoring system. So we should make, we try to make them normal. When they make them normal, actually they can do all their activities. So we should not control the patient so much that do this, do that, do this, do that. Nobody will listen in these days, do this, do that. So always we have to assess at every stage safety issues. If they are living alone, either we have to actually keep checking them frequently, or we have to try to arrange a nurse who is comfortable with them, or bring slowly to our and try to explain the family also clearly what are the issues. Cooking, driving are not so safe in the moderate stage. They may lose weight, they may be able difficulty in identifying the signals, and we have to keep them engaging in activities, new hobbies, which actually are important. In the advanced stage, this is my last but one slide. This last slide, senses. Actually, we have to keep their senses well preserved. Smell, we have to touch them, we have to perceive them, we have to actually give them music which actually appeases them. So these are all very, very finer things, and empathize with which we can empathize with them. We have to arrange a full-time caregiver in very advanced stages, and we have to always put a sister has told nutrition. We have to don't rush eating, give semi-solids if they frequently choke. So semi-solids, and we have to assist them to take, and we have to give fluids, frequent weight checks, and we have to maintain the as I told, people actually pass urine wherever they want and they don't feel any guilt. So what we have to do is we have to arrange a toilet schedule. I always tell in Kshetra, maintain a toilet schedule. Every 2 hours, take the patient to the bathroom, make her sit. Whether she passes urine or not, it is immaterial. Make her. After a few days, actually, every 2 hours, she goes to washroom and passes. So limit the fluid before sleeps and try to use Pampers at night. So, and physiotherapy, and we have to take care of good tooth care, skin care, as sister told very beautifully. These things are important, and elderly patients vaccination also is important. So especially for the kind of pneumococcal, meningococcal and other vaccines, yearly ones, and flu shots. And acute behavioral changes can happen in dementic patients, in elderly patients, very, very often, because of even smallest thing. For example, urine patient did not pass, there could be behavioral change. Motion patient could not pass, there could be a behavioral change. There must have been a very small wound that happened while walking. Because of that pain also, there could be behavioral change. Because in advanced stages, patient cannot communicate properly. If there is an acute behavioral change, we have to actually understand whether there was any change in the caretaker, whether there was any change, there was any rash, there was any constipation, there was any food that was not actually properly given. There are many things. If you just correct them, actually patients can become completely normal. So these are the advices which I would give. This actually was story was built thinking actually the amyloid pathology is increasing. So with that, slowly the disease progresses, and in that way actually these are all things caregiver may know and may have to know and plan things. First thing is we have to accept that patient has dementia. Accepting is half done actually. We have to start accepting and discuss with the doctor any other problems and plans. So with that, I actually end. Thank you very much for the opportunity. I would be willing to answer any questions too. Thank you.
Thank you, Dr. Muralidhar. I'm not able to see you on the video because my computer has some problems. Number one. But let me tell you, fabulous, absolutely fabulous. I think, yes, there are two questions before I post them to you. Let me tell you, you actually by this session, this is the last session of the 3 days. You personally, for me, you took me back to Dr. Sridhar Vaidiswaran, who spoke on the first day. He spoke extensively about various aspects that you ended up so beautifully. It's almost like a summing up of what really happens. I can tell you, I think people who are here, I'm already seeing excellent, very good explanation. You know, it's fabulous, very good comments are coming, which means I'm really delighted that you spoke so well. I think that talks about experience and commitment to educating others. I think more than being a doctor, you also need to prepare families to cope with it, because Kshetra cannot do much, or any institution cannot do much unless the families are able to cope with it. Very nicely said. There are two questions. There are many questions, but I'm going to post two questions considering the time and factor. Number one, first question is, does stroke cause dementia, Alzheimer's? Second question, what will happen to elderly people who develop progressive declining sensory motor deficit along with dementia? I'm going to close those two questions because I cannot have more questions, because I think Rajarajeswari has to come back for answering another question. Thank you.
Okay, sir. Actually, both questions are linked to some extent. So the first question is, can the patient have a dementia? Can the patient have vascular? Can you repeat the question, sir? First question, it just got off my mind.
The question, does stroke lead
Yes.
to dementia? This question has come from one of the persons from South Africa.
Yes, sir. Stroke definitely can cause dementia, sir. It is a straightforward answer. You may ask me why. I will give an explanation for that, because brain has memory areas. So there are memory circuits in the brain. Areas, rather than areas, we'll call them as circuits. It is like an electrical circuit. So you have a bulb actually seeing and staring. We see a bulb every day in our room, but there is a lot of circuit behind which is not actually seen. There is a circuit in the brain. Similarly, there is a memory also has a circuit in the brain. Whenever there is any problem in that memory areas, there will be dementia. For example, Alzheimer's, as I told, there are proteins which are accumulating. Similarly, if there is a blood vessel which is blocked to the memory areas, there will be dementia. For example, just today, now in the morning, yesterday I saw the patient came with the report. It is an acute amnestic event. Patient had memory problem. He is a father of a doctor, MBBS doctor. Actually, he came with me. Since yesterday, I'm not able to recollect what is happening. పొద్దున ఏం చెప్పాడో నేను గుర్తులేదు. I'm for South African doctor, I'm just telling. Morning, I ate something. I'm not able to recollect anything. My father is just to try to help us. I advised an MRI. MRI was showing swelling in the actually the memory areas, which we call as limbic encephalitis. It is actually a viral infection. Like that, any problem which affects the memory areas in the brain or behavioral areas in the brain, those are frontal lobes, there can be dementia. That is very simple. Second thing is, will there be any kind of motor and sensory deficits along with the dementia? Actually, dementias we classify into cortical dementias and subcortical dementias. Subcortical means there will be beneath the cortex there will be white matter. If there is involvement of the subcortex, there will be weakness, and also usually subcortex will be spared in Alzheimer's disease. It will be involved in mixed dementias. Usually a blood vessel became blocked on one side, one hemisphere of the brain, then there will be weakness of one-sided limb and right upper limb and lower limb. Then the patient can have such kind of things. They will have, they are, we call as vascular dementias, or sometimes if there is Alzheimer's pathology also in them, then it is a mixed dementia, because that is, I think I am clear on that. That's all.
Thank you, Dr. Muralidhar, for being so gracious, despite your time schedule, that you would been able to spare time to talk. Let me tell you,
Thank
I
you, sir.
really enjoyed. I've been listening to you every year. Let me tell you, this is not the first time I'm listening to you. Every time I invite you, I sit and listen, and I'm so delighted that the way that you have explained this time is far, far. I think experience matter, and I think you are proving a point that we all have a lot to learn from you. Fabulous. Thank you so much.
I'm very
And
humble, sir. Thank you for invitation.
very nice. You're all young people who are all delight to us. People like us who are willing to. We are all happy to listen to you. Now, with this, can I have Dr. Rajarajeswari answering those two questions before I
Yeah,
close the
yes,
chapter?
sir.
Yeah.
Yes, sir.
Okay.
Yes, yes.
You are so audible now. You are so audible now.
Wow,
Good.
okay, sir. Yeah. So how to prevent the choking to the patients with dementia means the patient mostly in the old age patients. To when you give the food to the patients means to raise the bed up to 30-degree angle. So when you give the patient in very upright positions and to give the when you give the food is mostly good for the liquid diet is very important for the choking and aspiration patients. When give for very semi-solid or liquid, when give for the spoon amount also very small quantity. When you the patient to having cough mean don't give the water. It's very, very important. When give the water also, if the cough did not stop, it will be continuous only. And that my presentation itself, I'm told to when the patient to having the problem of choking or aspiration means to give for the xanthan gum or ticket powder is very useful to prevent the choking and aspirations. Next one is nursing assessment. Yes, nursing assessment means when you patient to admitted in hospital means first to nurse to collect the when you doctor collect the history means to nurse also to join with us to collect the proper history to the patients. What are the complaint? The patient's sleep disturbances or appetite level, and to the patient toilet training, and to medicine how to take the medicine, the taking the medicine or to refusing the medicines, and to the patient agitation, restlessness, aggressiveness, to collect the when you collect the history, which is done with the doctors. To check the vitals of the patients. Yes, in case the patient admission time to having any agitations means the BP will be very high. To collect the ask the family members, the patient to having any previous BPs there, to taking any medicines, to ask collect the history from the family. Next one is to check the weight. Vital signs to check the weight to the patients is very important. So next one is to do the blood investigation. Yes, the patient did not do the any blood investigation, not measurement for the CBC and protein blood investigation, and do ECG also, and do for the any CT brains in case the patient did not do any CT scans report, do for MRI or CT brains. First, we take the CT brain only in case it's not clear, in case the patient is having any issues. After this only, the doctor will list for the MRI scan. So these are the assessment only we're doing from this.
Thank you, Dr. Rajeshwari. And before we close the last question,
Yes.
I don't want to miss this question because it's important.
Yes.
What about the psychological, this is for Dr. Muralidhar. What about the psychological problems and quality of life of caregivers who are dealing with dementia patients?
Yes, sir. Actually, caregiver burden is a very, very severe, very, very important. It has to be taken care of from time to time. What actually I do in my clinic, I will tell you, whenever a dementia patient comes, actually, I would suggest them, I give my number to them, because patient cannot come always. They actually frequently call me and tell me what is the status. Every time I check on either on the phone or either when they come to my clinic, I actually interview my patient. Once the patient consultation is over, I talk to the patient attendants also separately, and find what actually difficulties they are feeling, what kind of burdens they are facing. These things, the psychological burdens, it is not just about the patient too. There will be a lot of these social issues also. For example, I mean, I just to give a very common example that we encounter in our Indian families. So, I mean, for example, a mother-in-law or father-in-law is not well. The son could be very actually supportive, but the daughter-in-law may not have been very much supportive. So we have to actually interview. I take care of. I see how well they are actually cohesive, how social support they have. If there are any problems they are going through, I would actually suggest them to work together. That's what last slide I told you. We have to work together actually to help the patient and also understand. Everybody has to accept the diagnosis that it is not curable, and we should not give so much importance to the words which the patient actually communicates to us. The words of the patient may be very harsh. We may not be actually taking it very hard on us. So how much cohesion they have, I actually interview the patient separately, and if they have any kind of psychological issues, I actually most of the things solve myself. If it is going beyond my point, I actually tell them to take the help of a psychiatrist. That is actually the best way I can do at my clinic. And whenever on phone also, I always ask them, "Meer ela unnaramma? How are you? How is your family? Your kids are doing well." That such kind of things, words, they actually instill a lot of confidence in the patient attendants also, because they may be having lot of stress. If someone they need some ear to actually listen to their problem. That's all. We have to give that ear as a doctor, as a new psychologist, and as a actually the people who take care of dementia. We have to just wait and listen to them. That's all. So actually, this is a very important question at the end. I would just would like to tell you that the care of a dementic patient is together. We have to do it together, work together, and plan together, sit together. There should not be any kind of differences. Everybody should be on the same page to give best to the patient, and also so that there will be less burden on each and everyone in the team. Thank you.
Thank you so much, Dr. Muralidhar. I think we would like to probably close the session at this point of time. Before I close, I just want to tell you, I think the feedback forms for both. Dr. Muralidhar, you are always visible online on YouTube. There were a lot of people who were listening to all your talks on the YouTube today. So you
Yes,
are
sir.
online. So excellent feedback, number one. Number two is that please ensure that you fill up those feedback on both YouTube as well as on Zoom. So we would like to know what exactly you feel. And tomorrow is going to be a very important day for us, because we are taking the program away from the regular group. We are having 10 universities and colleges. We are combining together, having a program only for what is called dementia and role of social workers. So which means postgraduate students from across practically 10 colleges and universities are participating in this. We couldn't accommodate more because the capacity of the Zoom at this point of time is not more than 1,000. So we are looking at a large number of people learning what exactly to do. So that's going to be a very important session tomorrow. Those of you who are interested, please write to our office in case you want to listen to those sessions, whether you are a social worker or not. We'll be very happy to have as many of you as possible. Pavitra, is there Pavitra there? Pavitra, would you like to ask some questions to Dr. Muralidhar? Pavitra around there or not? I'll just wait for a day. Before that, I close. Yeah. Okay. So with that, I think we'll say thanks to all of you. I'm extremely grateful to all the three speakers, Dr. Dr. Manjari Tripathy, who, despite being extremely busy, she still ensured that she would address the group. Thank you so much for you, Dr. Manjari. Dr. Muralidhar Reddy, once again, I don't think I need to tell more often than what I said. Thank you so much. I want to tell you that Dr. Sridhar started and you ended so beautifully. Sridhar started with a lot of explanations and details, and you ended with the same kind of details and everything to just recap. Thank you so much. Rajarajeswari covered extensively on the nursing care. I think very important. I think this nursing care that she's talking about is technical aspects, whereas we are talking about the caregivers, which Dr. Muralidhar and Dr. Manjari Tripathy covered. And I would like to thank every speaker in the last 3 days for being very kind to be and join with us to stay together. Once again, thank you, Prabhakar of Heritage Foundation, Madhuri from Kshetra for sitting across, ensuring that people have access to this kind of information. And thank you once again, all of you, all the participants. I'm grateful to all of you. Take care. Thanks. All the best. Have a nice evening.